My pleasure. I'm happy to be here and thank you for the invitation. I really feel honored to share this topic with you on this conference. Congenital heart disease, emerging need for geriatric care and advanced care planning. And the first question that you may have is, how comes that there is an emerging need for geriatric care? Well, the answer can be found in a change in mortality over the past decades. This is a figure that is very illustrative for that. At the left side, you see the age distribution when people with congenital heart disease were dying. And some decades ago, you really see that the majority of the people died before the first year, before their first birthday. Some decades later, which is more representative for the current situation, you see that the distribution is completely different. It completely changed, and nowadays the majority of people with congenital heart disease are dying above their 60s, which clearly means that we are talking about a new population right now. And this reflects also in the epidemiology of congenital heart disease. We can say that the incidence of congenital heart disease, the number of children born with congenital heart disease each year, remains relatively stable. And it's indicated here in the light yellow zone. Due to the increased and improved survival, the number of adults with congenital heart disease is growing. And nowadays we have more adults with congenital heart disease than we have children with congenital heart disease. And in line with this, you also see, indicated in red, a growing group of older persons with congenital heart disease. And it's based on rough estimations, but by the year 2030, about 11% of adults with congenital heart disease will be 60 years or older. We know this today. We need to be prepared by that time. And of course, you can wonder, are we creating a new generation of cool grandmas? That's absolutely our ambition. However, today, the real situation is a bit more complex. So far, 2 studies have been conducted on older persons with congenital heart disease, and it is clearly shown that older persons with congenital heart disease are in need for a high resource utilization. They have high morbidity and they have a high mortality. So this is really a high demanding population, and we need to, once again, be prepared to take care of them. The urgent need for this was also observed or indicated by the American Heart Association, who thought it was even important to have a scientific statement on that. This statement is really guiding us in how should we look upon people with congenital heart disease who are growing older. But still, empirical evidence is limited. The key concept in everything here is accelerated aging. People with congenital heart disease, they are developing age-related conditions more often than the general population, and they develop it earlier than in the general population. And let me demonstrate this with a few study results. For instance, when we look at diabetes, and when you look at the rate of developing diabetes, in congenital heart disease compared to the general population, you see that this rate of developing is 35% higher than in the general population. When you focus on cyanotic congenital heart disease, this rate of diabetes is even 185% higher. Ischemic heart disease, rate of developing, it is double as high in congenital heart disease than in the general population. And when you look at specific, very vulnerable congenital heart diseases, it is up to 1,000 550% higher. So more than 15 times higher is this rate of developing ischemic heart disease. Dementia. You could think, well, it's all about the heart, and what has the brain to do with this? Well, the rate of developing dementia in congenital heart disease is 60% higher. And it's not only in the complex congenital heart defects. When you look at mild and moderate heart defects, it's also 50% higher. And when you look at early onset dementia in congenital heart disease, which means an onset of dementia before the age of 60, well, it is 160% higher. Stroke, 1000% higher. Erectile dysfunction, and Professor Schönenberger already referred to that. We don't have the rate of developing erectile dysfunction in congenital heart disease, but the proportion of ED is 280% higher. And it starts earlier. The figure that Professor Schönenberger showed, like it starts at the age of 50. Well, in our patients, it starts in the 4th and sometimes even in the 3rd decade of life. Yeah. And finally, cancer, which also can be seen as a kind of an age-related condition in many cases, 60 to 100% higher. So these are really compelling figures. Our patients are aging at a faster speed than the general population. And then the question is, how comes? What is the mechanism? How can we explain this? And I have to say, this is still a black box in many ways, so many unanswered questions. However, we start to get an understanding. And there are two aspects that I would like to indicate in this, which already helps us to understand what is happening here. And the first thing are telomeres. What are telomeres? None of us are molecular biologists, I assume. So telomeres are in fact the protective caps in our chromosome. And the telomeres protect the chromosomes for disintegration and for merging with other chromosomes. And due to the cell division, which we are constantly doing in our lifetime, these telomeres are gradually shortening. And this shortening of telomeres are both a marker, but also a cause for age-related conditions. So the question is, are the telomeres in people with congenital heart disease shorter, or is this shortening accelerated in people with congenital heart disease? The answer is yes. One publication so far looked at the telomere shortening in grown-up patients with congenital heart disease, and indeed it seems that the telomeres are shorter and the shortening is accelerated in these patients. Another aspect is the oxidative stress and the systemic inflammation. We could think it is all about the structure of the heart. No, the body, the entire body is constantly under stress. There is this systemic inflammation. And what we know is that both the telomeres and the systemic inflammation are related to each other, and apparently there is a bidirectional relationship. So telomere shortening increases the systemic inflammation, and the systemic inflammation increases the telomere shortening. So you're really in a circle of this accelerated aging. The question then is, what are triggers for this telomere shortening? And are there more triggers in congenital heart disease than in the general population? Because what we know that both the telomere shortening and the systemic inflammation, oxidative stress, it depends on our lifestyle. Smoking, alcohol, healthy diet, all are risk factors for telomere shortening. So that's not very different from the general population, I would say. But what are additional factors? Well, we have a generation of patients who have been taught that they should be very careful with their exercises. They should make sure that they don't not overexert because that could be bad for their heart. And that was with good common sense and with good purpose that this was said. But that means that there is a big group of patients who have restricted themselves in terms of physical activities. And due to this physical activity restriction, now they may have accelerated the telomere shortening. Another factor is the ionizing radiation. First papers on the relationship between ionizing radiation, even in a low dose, and cancer. And indeed, our patients are developing cancer more often, and the relationship with radiation is found. Indeed, so many of our patients have undergone catheterizations, CTs, and so on and so on. And this appears to have a long-lasting effect, once again, on the telomere reduction. But it's not only this kind of interventions, this kind of risk factors that plays a role. And something that is very important for us as nurses to know is depression is a factor that shortens the telomeres. So it's not only about the emotional and mental well-being of the patient, it really accelerates the aging. So we should never underestimate depressive feelings. And we know from the literature that patients with congenital heart disease have a higher risk for developing major depression. There are papers that show that in half of the patients there is at least a once in a lifetime episode of major depression or anxiety disorder. So depression is more prevalent in our patients and therefore may have contributed to this acceleration. Stress, and I'm not talking specifically about time pressure stress, but can you imagine what it means to go repetitively under examinations and knowing every time that maybe I got the news that I need a new operation? What about the chances for pregnancy? In my case, okay, I know for the population of congenital heart disease it's possible, but for my case, what is my life prospect? This is a constant factor of stress for our patients. Once again, it contributed. And one of the maybe most surprising thing, loneliness. We know that loneliness is a social determinant of health. And quite often we thought, well, it has to do with social support and the lack of social support. Well, that will play a role, but not only. There is a biological pathway. Loneliness appears to be a risk factor for telomere shortening. And we know that social isolation is sometimes, and a lack of integration is sometimes an issue in certain subgroups of people with congenital heart disease. An extra risk factor for aging. So, I said it's all about accelerated aging. Yes, indeed. Geriatric syndromes will occur or are occurring in our patients, being cognitive decline, immobility, falls, failure to thrive, sensory alterations, changed response to medication, and altered psychosocial profile. We need to have geriatric expertise in our teams. The patients are coming, they are coming with this kind of syndromes, with this kind of conditions. We need to have the answer by the time that they are with us. So, yes, frailty is an issue, and once again, Professor Schönenberger talked about that, but we need to know, we don't have to wait until the people are in their 70s. We should be aware about pre-frail statuses relatively early in their life. And so far we don't have any evidence. We need research to see when is this pre-frailty starting in people with congenital heart disease. And we know it will start earlier than you would expect. So, I was talking about the successes in survival. the changing, more people that are dying above their 60s, which is to a certain extent, of course, good news. However, we still lose a lot of people prematurely, people that die way too early. And that means, and that's the reason why it's also important to have attention for the end-of-life aspects, and by extension, advanced care planning. The thing is, in congenital heart disease, people can die in different ways. And when you look at in the literature on end-of-life research, there are 4 theoretical trajectories of dying. And to be honest, these 4 trajectories all occur within the population of congenital heart disease. We have people that have a sudden death. They seem to do good until a certain moment and they drop dead. We have people with a terminal illness. For instance, people with Fontan circulation, they develop, for instance, liver cancer, and it's going down and they die. We have people with organ failure, our heart failure patients. They are treated, going better, but still going down, do a new episode of exacerbation, treated, and so on. So that's also the pathway towards that. And then the frailty status, and that's the thing we know least about. What do we know about trajectories of dying? Well, we don't know how many patients can be categorized to these trajectories. That's a blind spot. But what we do know is actually pretty sobering. If we look at data on the last year of life in congenital heart disease, it is found that 39% of the patients have an inpatient admission, and equally 39% are in need for ICU admissions. These numbers are higher than in cancer patients. This means that the last year of life in congenital heart disease is more burdensome and more expensive than in cancer. The work of Daniel Tobler is very informative in this matter. He was one of the first looking at preferences and needs of patients. So if you ask patients what is the preferred place of dying, then 53 would say, I'd like to die at home. What is reality? 67 die in the hospital. If you ask patients, has end-of-life planning be discussed with you? 1% said yes. If you ask physicians, clinicians, did you discuss end-of-life with your patients? 50% says yes. If you then ask, when should we start talking about it? Is there a certain appropriate moment? Should we start early, even if the end of life is not near? Should we start talking about it then? Patients, 62% say, yes, you need to start early. Even if I don't need it, I need to think about it, and I need to have the chance to think about it and to discuss this with my loved ones. If you ask clinicians, do you think it is appropriate to start an early end-of-life discussion? 38% says yes, it is appropriate. So we clearly have a mismatch between the needs of the patients and what we provide as healthcare professionals today. Okay, trajectories of dying is one thing. How does this translate into end-of-life models? And until some years ago, the end-of-life model looked like this. You do curation as long as possible, and if that is no longer possible, then you start palliative care. So it was really a dichotomic way of looking at the aspects. However, more recently, some people say, well, we should rather look at a gradual evolving process, where palliative care starts to get slowly integrated and slowly get a place in the care, whereas curative care is reducing in attention. And very recently, there are even people who say, well, the model should look like this. Palliative care, in whatever we do, we always need to have the end in mind. And we always need to give that a place as well. I don't know what is the best model, just because we don't have any data on that. We do have so far an opinion paper that is reflecting on the different modes of that and how this can translate into end-of-life care. But definitely we need to have more support, more scientific support to underpin this, and therefore we need more research. But we don't have to wait until we have the evidence to do something. There are a lot of things we can already do today. So let me come to the conclusions of this presentation. The number of older persons with congenital heart disease is growing. Aging in our patient population is accelerated due to the presence of additional risk factors for telomere shortening and systemic inflammation. And of course, there will be other mechanisms of impact as well. There is evidence that psychosocial factors contribute to accelerated aging, and therefore we as nurses, psychologists, social workers and so on, we have an indispensable role to play for our patient population, just to have an impact on this aging process as well. Frailty and geriatric syndromes emerge in congenital heart disease. End-of-life care, as we provide today, is suboptimal, and there is clearly a mismatch between the patient needs and what we provide currently. And finally, the role of an integrated palliative care and other end-of-life care models in congenital heart disease is still to be evaluated. Thank you very much.